Imagine stepping back from the operating table. The rhinoplasty went perfectly.
Oh, the dream scenario.
Right. I mean, the profile is exactly what you planned, the tip projection is ideal, and the patient is just thrilled. But let's say 6 months later, that same patient walks back into your clinic.
And you can already guess what happened.
Yeah, the tip of their nose has dropped dramatically. It literally looks like a parrot's beak.
A classic devastating complication.
Exactly. So today, we're decoding the exact structural failures that cause the board's most feared complications. To you, the fellow plastic surgery resident tuning in, welcome to this high-yield revision deep dive.
We're skipping the generic fluff today and jumping right into the deep end.
Because time is your most valuable asset right now. And rhinoplasty is one of those topics where the sheer volume of anatomical detail can just feel completely overwhelming.
It really can. But there's a logic to it, I promise.
Right. So today's mission is singular. We want to help you master rhinoplasty for your board exams, specifically the FRCS in plastic surgery.
We're going to cover the foundational anatomy, the preoperative assessment, operative techniques, and of course those classic board-tested complications.
And we're doing it by focusing on exactly how these concepts are tested.
Yeah. Because it is all about high-yield recall.
Yeah.
The boards don't just want you to, name a deformity. They want you to understand the exact physical failure that caused it in the first place.
Absolutely. And speaking of high-yield recall, here is an urgent reminder before we make our first incision today. If you want to absolutely crush your exams, you need to head over to medsynclimited.com.
Highly recommend it.
Get the FRCS Plastic Surgery Anki deck. I mean, it contains over 6,000 questions, all perfectly arranged by topic to help you lock in the key facts. And it is directly based on the textbook keynotes in plastic surgery.
Active recall is literally the only way this volume of information actually stays in your brain. It's the ultimate tool for this exact stage of your prep.
It really is. Also, do not forget to hit follow on your app right now to catch all our future revision sessions and rate the show if you learned something valuable today.
All right, let's get to work.
Let's do it. So, before a surgeon can even think about altering the nose, they intimately have to understand the foundational architecture.
Right. I mean, you can't remodel a house if you don't know which walls are load-bearing.
Exactly. Structurally, we divide the osteocartilaginous framework into thirds. So let's map those out. The upper third is the bony vault.
Yeah, that's your rigid foundation. It consists of the paired nasal bones. And for the exam, you need to know exactly what they articulate with.
It's never just the nasal bones.
No, never. Superiorly, they interdigitate with the nasal process of the frontal bone. Laterally, they meet the frontal process of the maxilla.
Right.
Posteriorly, they articulate with the perpendicular plate of the ethmoid, and medially, they join each other.
Okay, so that is the upper rigid third. Moving down to the middle third, we transition from bone to cartilage. This is the upper cartilaginous vault.
Correct. This middle third is made of the paired upper lateral cartilages, and those sit on either side of the dorsal cartilaginous septum.
And we really need to pay close attention to the overlap areas here, right?
Oh, absolutely.
Yeah.
Because this is where structural integrity is made or broken. The nasal bones overlap the upper lateral cartilages at what we call the keystone area.
The keystone area. I picture it like the actual keystone of a stone archway.
That's exactly how you should visualize it.
Because if you disrupt that specific junction aggressively, the whole middle vault just wants to cave in.
It does. It collapses.
Mm.
And inferiorly, there's another overlap you have to know. The lower lateral cartilages overlap the upper lateral cartilages at what's known as the scroll area.
Which brings us to the lower third, the lower cartilaginous vault. And this is where the anatomy gets incredibly three-dimensional. I mean, it's not just a flat piece of cartilage.
No, not at all. It's highly complex. The lower third consists of the paired alar, or lower lateral, cartilages. Each one has a medial crust that runs down through the columella, a middle crust that essentially forms the nasal tip, and a lateral crust that passes superolaterally.
And this is a point I really want to emphasize because it trips up a lot of residents. Those lateral crua do not just curve along the margin of the nostril.
Oh, they don't.
They actually incline obliquely upwards and outwards.
Mm-hmm.
Which is counterintuitive, right? You'd think they'd just trace the nostril rim, but they swing up.
Yeah, and that completely changes how you approach a tip resection. Because if you assume they just trace the margin, you are going to resect the wrong tissue or completely destabilize the airway.
Precisely. And speaking of the airway, that leads us directly into the valve anatomy. The boards absolutely love to test the strict boundaries of the nasal valves.
Oh, it's a guaranteed exam question.
So let's unpack the internal versus the external nasal valve. The internal nasal valve is the narrowest part of the entire nasal airway. It's the primary choke point.
Right. And structurally, it's formed by the junction of the caudal edge of the upper lateral cartilage with the nasal septum.
And in a normal, healthy airway, what is that angle?
It's between 10 and 15 degrees. That 10 to 15 degree metric is a crucial number to just memorize. If that angle narrows even slightly, the patient experiences profound obstruction.
Wow, okay. Now, contrast that with the external nasal valve, which is situated further down in the lower third.
Yeah, and the boundaries here are different.
I used to get the boundaries of the external valve mixed up all the time, but it helps to just trace the physical opening of the nostril in your head.
That's a great trick. So the boundaries are the caudal edge of the lateral crus, the soft tissue,
Right? The soft tissue.
the membranous septum, and finally the nostril sill at the bottom.
Perfect. Okay, so now that we have the framework, let's talk about the soft tissue envelope and surgical planes. When you're elevating the skin flap during a rhinoplasty, you are navigating a vascular minefield.
You really are.
Elevating that skin flap safely is like working in the ceiling of a house. You have to stay below the drywall to avoid ripping out the crucial electrical wiring. What is that exact anatomical plane we must respect to preserve the blood supply to the nasal tip?
I love that analogy. So to build on your house metaphor, the electrical wiring, your arterial supply, runs specifically within that drywall.
Right.
And for the nose, that drywall is the musculoaponeurotic layer. The nasal skin is predominantly supplied by the facial artery, specifically its superior labial and angular branches, and the ophthalmic artery, which gives off the dorsal nasal artery. All of these arteries travel right in that musculoaponeurotic plane.
Okay, and what about the plumbing? Like the venous drainage and lymphatics?
The veins and lymphatics travel more superficially in the subcutaneous plane. So think of that as the paint over the drywall.
Ah, okay.
Therefore, your dissection, particularly during an open rhinoplasty where you're lifting the entire envelope, it must be deep to the musculoaponeurotic layer. You want to be completely behind that drywall.
Because if you dissect too superficially and tear through that layer,
You risk injuring the arterial supply to the nasal tip. And the result of that is disastrous ischemic necrosis.
stay deep to the musculoaponeurotic layer. You are literally sliding right on top of the perichondrium and periosteum.
Exactly.
Okay, so we have the foundational anatomy locked in. Now, we shift our focus from textbooks to the consultation room. Recognizing functional deficits and red flags during the preoperative assessment dictates the entire surgical plan.
It really does. It's where you make or break the case.
So for the boards, what specific history questions are mandatory before you ever offer a patient a surgery date?
You need to screen systematically.
Yeah.
Function and medical issues come first. Do they have problems breathing? Any history of frequent nosebleeds, allergic rhinitis, or chronic headaches?
Yeah.
You absolutely must ask about prior trauma or previous nasal surgeries because scar tissue changes everything. And you also need to inquire about their profession.
That's a good point, because if they are a wine taster, a chef, or, a perfumer, their livelihood depends entirely on their olfaction. A minor complication for a regular patient could be a career-ending disaster for them.
Exactly. And crucially, you have to ask a very direct question. Have they ever taken drugs nasally, particularly cocaine?
Because of the profound vasoconstriction cocaine causes, right? Leading to the risk of septal perforation and massive mucosal damage.
Yes, you definitely don't want to try harvesting a septal graft from a septum that's already compromised by cocaine use.
But it's not just the physical history that the exam focuses on, right? The boards frequently test the psychological assessment.
Absolutely. The psychological screening is arguably more important than the physical one. You have to evaluate their expectations and their motivations.
So what are we looking for?
Well, a healthy patient needs to articulate specific, realistic anatomical concerns. They should point and say, I don't like this dorsal hump, or I feel my tip is too bulbous. That is actionable.
As opposed to just saying, I hate my face, do what you think is best to make me beautiful.
Right, that's a huge red flag. But more importantly, you must screen for their emotional motivation. What defines an unhealthy motivation in this context? It's seeking surgery to fix external, entirely unrelated life problems.
Like thinking a rhinoplasty is the magic bullet that will attract a straying partner back, or somehow cure their depression or relieve tensions within their family.
Exactly. Because what happens, you perform the surgery, The nose looks anatomically flawless.
Yeah.
But those underlying relationship problems or personal insecurities, they persist following the operation.
Right, the nose didn't fix the marriage.
Exactly. And this leads to profound emotional disappointment for the patient, and they will direct that anger at you, regardless of whether your surgery was technically perfect. A technically perfect nose on an unhappy patient is still considered a surgical failure.
That is a critical concept for the boards and honestly for real life. Let's move to the physical clinical examination. We talked about the internal nasal valve earlier. How do we clinically differentiate internal valve collapse from other sources of airway obstruction, like a deviated septum or enlarged turbinates?
This brings us to a classic, highly tested clinical maneuver, Cottle's test. You're sitting directly across from the patient. You ask them to breathe quietly. Then you place a couple of fingers on their cheek, right adjacent to the internal nasal valve, and apply lateral traction. You gently pull the cheek outward.
And because the soft tissues are connected, this physical maneuver manually pulls open that internal nasal valve, widening that 10 to 15 degree angle we talked about.
Yes.
So if pulling the cheek outward relieves their sensation of obstruction, it's a positive caudal sign.
Exactly. A positive test strongly indicates that an abnormality or dynamic collapse of the internal nasal valve is a significant contributor to their airway issue.
But I want to pause and push back right here because board examiners love to test the exceptions to the rules. If you're staring at a multiple choice question, they won't just ask what the test is, they will ask when it lies to you. When does Cottle's test give us a false negative?
Excellent point. You will get a false negative if there is severe internal scarring or intranasal synechia.
Synechia, right.
Synechia are essentially bridges of scar tissue that fuse the internal structures together. In those cases, pulling laterally on the external cheek won't actually open the internal valve because that thick band of internal scar tissue is physically holding it shut.
Wow. So the patient won't feel relief, so you might assume the valve is fine, but the valve is actually the exact source of the problem.
Yeah.
That is a classic board trap. Synechia equals a false negative on Cottle's test. Don't fall for it. All right. The assessment is complete. It is time to scrub in and operate. The boards frequently test the exact anatomical boundaries of various surgical incisions. Let's establish our overarching approach first. Open versus closed rhinoplasty.
In a closed or endonasal approach, all incisions are made strictly inside the nostrils. There's no external scar whatsoever, and the soft tissue dissection is generally less extensive.
So when do we use it?
It's ideal for patients who require an isolated, straightforward dorsal hump reduction or very minor tip corrections. The significant downside is that it requires immense expertise and spatial awareness because the anatomy isn't fully exposed. You are essentially working through a tunnel.
And the open approach, because this is what we see most commonly today for complex cases.
The open approach gives you brilliant, full visualization of the entire nasal framework in its natural state. It's best for extensive tip manipulation, complex asymmetry, and particularly post-traumatic or revision rhinoplasty, where the anatomy is unpredictable.
But it requires a transcolumellar scar.
Yes, it does.
And we don't just make a straight line across the columella, right? We
Mhm.
usually interrupt that incision with a scare step or an inverted V pattern. Why is that?
To prevent linear scar contracture. A straight line scar can contract and notch the columella over time, whereas an irregular geometric shape breaks up those forces and heals almost invisibly. But remember, the open approach also results in a longer operative time and prolonged post-operative tip edema because you're disrupting more lymphatic drainage.
Now let's clearly define the internal incisions, because the nomenclature here is heavily tested. I want to strictly separate a transcartilaginous incision from an intercartilaginous one.
It's all in the prefix. A transcartilaginous, also called an intracartilaginous incision, passes directly through the vestibular lining and straight through the long axis of the lateral cross of the alar cartilage itself.
Okay, through the cartilage.
Right. You're dividing the cartilage into a superior cephalic portion, which you might remove, and an inferior caudal portion, which stays.
And how much of that inferior caudal rim absolutely must be left behind for support? This is a huge safety threshold.
You must leave a minimum of a 5 to 6 millimeter intact caudal rim to support the ala. If you violate that rule and leave less, the patient's nostril margin will collapse dynamically when they breathe in.
5 to 6 millimeters, write that down. And the intercartilaginous incision.
Inter means between. This incision does not cut through cartilage. It passes right between the upper border of the alar cartilage and the lower border of the upper lateral cartilage.
It's a simple distinction, but crucial for the exam. Trans is through, inter is between. And what about the transfixion incision?
A transfixion incision passes vertically through the membranous septum. It sits right between the rigid cartilaginous septum superiorly and the medial crura of the alar cartilages inferiorly. You use this to gain wide access to the caudal septum.
Excellent. So we've made our incisions, we've accessed the framework, and we've reduced a large bony and cartilaginous dorsal hump with an osteotome or a rasp. We are now left with what's called an open roof deformity.
Right.
Imagine cutting the peak off a tent. You are left with a literal gap between the side walls, the nasal bones, and the central pole, the septum. We have to close that gap to recreate a natural narrow nasal bridge. We do this using osteotomies, controlled fractures of the bone.
Yes, we do.
But first, here's where it gets really interesting, and it's a classic trick question you will see on the FRCS. We universally call them nasal bone osteotomies, but that's actually a misnomer, isn't it?
It is, and this raises a very important anatomical point for the exam. Despite the colloquial name, when you perform a lateral osteotomy to close that roof, the majority of your cut is actually passing through the frontal process of the maxilla, not just the tiny nasal bone itself.
Which is wild to think about.
Yeah, the nasal bones are surprisingly small. The maxilla makes up the bulk of the lateral sidewall of the nose.
Keep that detail in your back pocket. They will absolutely try to trick you with it. All right, let's break down the specific trajectories of these osteotomies. Start with the low to high lateral osteotomy.
For a low to high osteotomy, which is typically used for small to moderate open roof deformities, you start your cut low at the nose-cheek junction, right on the bony rim of the piriform aperture adjacent to the inferior turbinate.
Okay, starting low.
And then you drive your osteotome upwards, ending the cut high, meaning closer to the nasal dorsum, just inferior to the medial canthus at the nasomaxillary suture.
But you don't actually cut all the way through the bone at the very top, right?
Correct. The superior end of the cut is left intact. You complete the maneuver as a green stick fracture by manually pressing medially against the bony vault. This allows the bone to hinge inward toward the midline, closing that open roof like a trapdoor.
Ah, clever.
And because you leave that superior attachment, the bone is stable. Crucially, this trajectory tends to preserve the internal nasal valve because the lower lateral segment doesn't collapse inward as much.
Contrast that mechanism with the low-to-low osteotomy.
Low-to-low is a more aggressive maneuver. We use it for very large open roof deformities or naturally broad noses. You start at the exact same site on the piriform aperture, but your trajectory is lower. You end just below the medial canthus, much closer to the cheek.
Which means the entire bony segment you are mobilizing is much wider.
Yes, and because of that wider geometry and the thicker bone, you can't just rely on a simple green stick fracture. You often have to perform an additional transverse osteotomy, a horizontal cut near the medial canthus, to fully mobilize the bones before you can fracture them.
And here is the clinical trade-off. By mobilizing that entire wide segment and pushing it inward, you are physically narrowing the cross-sectional area of the nasal airway. In fracturing, a low-to-low segment can severely narrow the internal nasal valve.
It certainly can.
Which means you will likely need to proactively place spreader grafts to prop that valve back open. Let's define those right now, since we're on the topic. How do spreader grafts actually work mechanically?
Spreader grafts are essentially physical shims. They are matchstick-like pieces of autologous cartilage. You place them longitudinally right between the dorsal nasal septum and the upper lateral cartilages.
Okay.
By acting as physical spacers, they wedge the upper lateral cartilages outward. This widens the middle vault and prevents the inspiratory collapse of that narrow internal nasal valve we discussed earlier.
What about the double-level osteotomy? When do we use that?
That is reserved for extreme cases. Very large open roof deformities, extremely convex or rounded bony vaults, or excessively broad noses where a single fracture line won't achieve a straight contour. You perform a medial osteotomy first, running parallel to the septum, and then you follow it with a standard low-to-low lateral osteotomy. You are essentially breaking the sidewall into multiple segments to flatten a severe curve.
All right, with the bony vault reconstructed and the open roof closed, our final aesthetic focus is the lower third, the nasal tip and dorsum profile. This relies heavily on grafting, and grafts are exceptionally high yield for exams. Let's start with the structural combination. What exactly constitutes an umbrella graft?
An umbrella graft is a very specific, powerful combination of two distinct grafts used to rebuild the tip. First, you place a columellar strut graft. You insert this vertical piece of cartilage longitudinally between the medial crura of the alar cartilages, and you rest the base of it right on the anterior nascent spine.
So that acts as the handle of the umbrella, providing rigid, unyielding support to maintain tip projection.
Exactly. And second, you add a tip onlay graft, a horizontal cap of cartilage sutured right on top of the tip defining points. The vertical structural strut, combined with the horizontal onlay cap, forms the visual of an umbrella.
It provides immense projection and definition. Now, if we're augmenting the bridge itself, what is the Turkish delight technique? And I want to know exactly why we use this specific method.
The Turkish delight is a highly effective technique for augmenting the dorsal bridge, often to camouflage minor contour irregularities or treat a saddle nose deformity. You take autologous cartilage, usually septal, and you morselize it, meaning you crush it mechanically into tiny semi-fluid pieces.
You can't just inject loose, crushed cartilage into the nose. I mean, it would scatter or the body would absorb it unpredictably.
Exactly, which is why the second step is crucial. You wrap that crushed cartilage in a layer of Surgicel, which is an oxidized, regenerated cellulose hemostatic agent. This creates a moldable, stable sausage of cartilage.
Okay, a sausage of cartilage.
Yeah, and the Surgicel acts as a temporary stabilizing scaffold. It holds the cartilage fragments in the exact shape you want, while the body's fibrous tissue slowly engrows and solidifies the graft over the following weeks.
It's a brilliant solution for unpredictable absorption. Speaking of augmentation, what about alloplastic or synthetic options? I know silastic implants are often heavily discussed in the context of Asian rhinoplasty to gain significant dorsal height and tip projection, where autologous cartilage might be scarce. What are the board-relevant complication rates there?
Well, the most common synthetic shape used is the dorsal columellar L strut. The obvious benefit is that they completely avoid donor site morbidity. You don't have to harvest rib or septal cartilage. But they carry specific serious risks.
Like what?
Displacement, localized hemorrhage, and supratip deformity can occur, requiring surgical removal in about 5% of cases overall. But the absolute key statistic to memorize for the exam is the extrusion rate. The rate of the implant actually wearing a hole through the skin or mucosa and extruding is 0.5%. And this risk skyrockets if an oversized implant is used that puts too much tension on the soft tissue envelope.
Wow, 0.5%. Let's circle back to something vital. Whether you are creating spreader grafts, columellar struts, or Turkish delights, you are usually harvesting that cartilage from the patient's own septum. But there is an absolute non-negotiable cardinal rule when harvesting septal cartilage. What is it?
You must preserve a contiguous 1 centimeter wide L strut of cartilage along the dorsal and caudal margins of the septum.
Meaning 1 centimeter of width along the bridge and 1 centimeter of width along the columella, forming an L shape.
Yes. If you get greedy and take too much cartilage, violating that 1 centimeter rule, you destroy the primary structural support of the entire lower two-thirds of the nose. The result is a devastating iatrogenic saddle nose deformity.
Which is a perfect segue into our final segment. Every single surgical maneuver we have discussed today carries specific, predictable risks if executed poorly. Exams test the precise anatomical failure behind these late deformities. Let's finish with the classic triad. What exactly goes wrong mechanically to cause a polybeak deformity?
A polybeak is characterized by a loss of the supratip break, that subtle dip just above the tip, combined with tiptosis, meaning the tip physically drops downward over time. It quite literally looks like the curved beak of a parrot.
And why does it happen?
This happens for two main reasons. First, you might under-resect the cartilaginous dorsum relative to the bony dorsum, leaving a literal bump of cartilage behind. Or second, and more commonly, you fail to maintain adequate tip support. You cut the ligaments, you don't put in a columellar strut, and over the next 6 months, gravity and scar contracture pull the tip down, causing the supratip area above it to appear overly prominent and bulky.
The tip falls, the cartilage above it pushes up. Okay, what about the inverted V's deformity? What is the mechanism there?
The inverted V deformity is a visual where the caudal borders of the nasal bones literally skeletonize and show through the skin as a sharp upside-down V shape. Why does it happen? It occurs due to a complete loss of support of the upper lateral cartilages following an aggressive dorsal hump reduction.
Because of that keystone area.
Exactly. Remember that keystone area we talked about? If you shave down the dorsum and disrupt that junction without proactively resupporting it, often with spreader grafts, those upper lateral cartilages just cave in. They collapse inframedially into the airway. Without those cartilages propping up the skin, The rigid, bony, inverted V shape of the nasal bones above them becomes completely exposed and visible.
The soft tissue falls away, and the bone underneath is unmasked. And finally, the rocker deformity. Why does the bone rock?
This goes back to the physics of our osteotomies. Rocker deformity occurs when your lateral osteotomy cut is taken way too far cranially. Instead of stopping near the medial canthus, you extend the cut up into the thick, dense bone of the frontal process of the maxilla or the frontal bone itself.
And that thick bone does not want to fracture cleanly.
No, exactly. When you press medially to attempt the infracture, that thick superior end doesn't break. It acts as a fulcrum. The bone rocks outwards laterally at the top, just like a seesaw hitting the ground. The bottom goes in, the top kicks out, and it becomes a visible, palpable bump under the skin near the eye.
And if you are in the OR and that happens, how do you fix it?
You cannot just push harder. You have to back out, take your osteotome, and make a new transverse osteotomy at a lower, more appropriate caudal location. This breaks the lever arm, allowing the lower segment to move medially without levering the top portion outwards.
So we've covered a massive amount of ground today, from the vault architecture and valve angles to the physics of osteotomies and the exact structural failures of late deformities. You have everything you need to crush these questions.
You really do.
But as you go back to your studying, I want to leave you with a final thought to mull over. We have spent this entire deep dive talking about the intricate tightrope of cutting, rasping, and strategically harvesting autologous cartilage to rebuild the nose. We rely on the patient's own septum, rib, or ear to fix these structural deficits. But look at the trajectory of our field. With the rapid advancement of tissue engineering and 3D printed bioscaffolds, you have to wonder, will the next generation of plastic surgeons even need to harvest septal cartilage at all? Will the golden rule of the 1 centimeter L strut eventually become a historical artifact, replaced by off-the-shelf, perfectly engineered scaffolding that simply absorbs and turns into native cartilage? It is a fascinating evolution to watch.
It changes the entire paradigm of how we view donor site morbidity. It's truly wild to think about.
Exactly. All right, that is all for today's revision session. Do not forget to hit follow on your app right now, rate the show if this breakdown helps clarify your studying, and leave a comment or question below. We read every single one of them.
We really do, so please reach out.
And one last time, head to medsynclimited.com to get the FRCS Plastic Surgery Anki Deck to lock in every single mechanism we just discussed. Keep studying hard, trust your preparation, and we will see you on the next deep dive.